So yes, I'm going to talk about the risk stratification. What is actually the term? What does the term risk stratification actually means in medicine? It is actually the process of separating patient populations into high risk, low risk, and ever important raising risk groups with a view to predict the complications that you expect for each group so that you prioritize your resources, put the money where they need it, and try to prevent complications and make it cost effective. So it's important in empowering informed choice regarding surgery, in giving informed consent. You need to tell them about the risks and the benefits. And the patient, they ask for numbers, say, you know, how likely is I get better? 50%, 70%, 90%, they like numbers which we can't give, but they get an idea with this stratification. And it's a useful tool in determining the appropriateness of surgical management in spinal deformity. Yesterday we were discussing about, you know, whether to do a decompression alone or a short fusion, floating fusion, or a full reconstruction. So when we talk about the adult deformity surgery and the risk stratification, we're not talking about the reasonably low risk adult deformity surgery, which is like this guy who is 47 and he decided to deal with his idiopathic kyphosis at a later age, or this lady who is 57 and she has an adolescent idiopathic scoliosis left untreated, and despite the fact she has osteoporosis, I think this kind of surgery is a reasonably low risk or, you know, straightforward. We are talking about the real problem in deformity surgery, which is, unfortunately, most of the time is iatrogenic. It's undercorrected deformities, is iatrogenic deformity, like the one you see. It's the adjacent segment disease from Digen's surgery, the PJK, the PJF in deformity correction, the infections. There are also problems that arise from decision-making issues, wrong indications. I show you examples that, you know, patients are in trouble because of a wrong decision in the index surgery. And of course, yes, there are patient-related factors that, such as comorbidities in a patient with a deformity, or a major deformity, aggressive deformity that requires aggressive approach. So with regards to the complications of the deformity surgery, 20 years ago, we tend to underestimate the risks of deformity surgery. We talk about adult deformity correction risks as if we talk about Digen surgery. But being honest with ourselves, recently we found out that the complication rate is something in between 10 to 86%. I think the consensus is 40% to get one complication at least. And one out of, half of them may have a serious complication. You know about the studies. I mean, someone mentioned yesterday one of these. We can get serious complications, not just a dural tear, tear with CSF leak and wound healing problems. You can have, actually from the Σκολίωσης study, we know that 1 out of 4 patients at discharge experience a decline in neurological outcomes, like, you know, a neurological deficit, which stays in 1 out of 10 patients at 6 months, which is serious, isn't it? And this one from the JNS, it shows that almost 70% of the patient would experience at least one complication from deformity correction in adult deformity. We are always talking about adult deformity, okay? And 1 out of 3 would need a revision surgery. And we all know that as far as we go with the correction, the risk raises, same as the benefit of the patient if the operation is successful. So we need to know where to stop in between, in the spectrum of decoration and restoration. Because, you know, we need to be very accurate with the estimation of the risk and set up reasonable and accurate standards for complications, because we end up, the deformity surgeon will end up like the dinosaurs we won't exist, because no one would pay for this operation. There are many public systems around the world, they banned deformity surgery in adults. And yes, there are metrics in health, like the quality, which is something measurable, is the quality of life within the span of the remaining life. So with the blue, you can see the quality of life on on this here, and the time left until death. So an intervention can expand the life and improve the quality, and then you get more of quality. So this is the quality gain from an intervention. And unfortunately, we are not very good, because to make it value for deformity surgery, although we know that deformity correction is the only thing that can work you know, is the only option that can give you a quality gain, it's very expensive. And to make it cost effective, it needs to last for at least 10 years to be comparable with other operations that are very successful, like the bypass, for example. The bypass is 10 times cheaper than deformity surgery, the quality. And why is that? Because we have high complication rate, increased length of stay at the hospital. Our procedures are becoming more and more complex with more osteotomies. Well, used to when I've first written this presentation, the intent now is to go simpler. So the question is, can we minimize our complications with pre-op and perioperative optimization of the patient? And this is part of the risk stratification process, to make it safer by developing a strategy that would optimize the patient, the surgeons, the means we use to correct the deformity and eventually to get the best outcome. So there are a few strategies I put together, preoperatively, intraoperatively, and postoperatively, which I analyze. So preoperatively, we need to, first of all, meet with the patient's expectations. We need to explain to him what we can do and see if it is good enough for him or her to go ahead with surgery and take the risk. We definitely, I insist to that a lot, we definitely need to treat osteoporosis. So DEXA scan of worse than -3 for me is a no-go. 2.5 to 3 depends on the age and on the deformity. But I tend to give teriparatide and treat the patient preoperatively and 6 months postoperatively. BMI, if we can improve, it would be of help, great help, but this is difficult. Most of the time they tell you I can't move, I can't lose weight. So you need to take in consideration the home situation, the social support assessment, and address all this. You can't do a scoliosis correction in a lady with no support and let her go. She will fail. And smoking cessation is important for such a big surgery, in my opinion. So patient optimization, such as pulmonary function, cardiac function optimization, nutritional status, and psychological evaluation, bone density, as I said. Look for tandem stenosis, especially at the neck. Do a clinical examination there. Many times I realized that a deformity patient had myelopathy, for example, and if you put them down prone for 8 hours, they wake up with serious problems. Do a detailed neurological examination and document. Get involved the neurophysiology if needed, if there is a neurological deficit or a long-standing neurology. And get everything ready for surgery in advance. Don't expect your scrub nurse to have everything ready for you in theater before you think about it. So there's some things, special things you need to tell people to get. And also, one thing you should not forget is to get a second surgeon with you. For deformity surgery, adult deformity surgery, I think this is a must. And you need to think about and discuss your plan with other colleagues that can give you opinion on that and tell to you if what you think it's a great thing to do, if it actually is. So you need an MDT, and we don't have MDTs the way they do in the UK, for example. That's a random MDT meeting here. Yeah. But at least get a colleague of you that you appreciate his opinions, and discuss the case, discuss with the physiotherapy. The physiotherapist you use, because there is a lot of work in the rehabilitation that needs to be done. And also your scrub nurses, and anyone that can help with the situation, they need to be involved in the discussion. So intraoperatively, there are a few things that are standard, such as the blood conservation and fluid management should be very clear to your team. I personally use Cell Saver, Tranexamine. There is a transfusion protocol post-op, so we don't need to discuss it all the time. Another important thing is to communicate effectively with your neuromonitoring. Be sure they know what we do as a team, and develop a protocol in case of a change. So antibiotic prophylaxis, of course, is important post-operatively for me. I give antibiotics until the drains are out. If any concerns with the wound, I keep the antibiotics. Blood sugar control for the diabetic is crucial, as normothemia. So I mentioned about the two consultants. There are lots of studies to support that, but I don't think we need studies for that, because we all know with a good colleague next to us, the outcomes are better. And you need to be very reasonable with your strategy, the correction strategy, because remember, you are not aiming for the perfect X-ray. You are aiming for a patient who is happy with the least pain you can get after the operation, and a construct that will survive in time. So you need both. I'm not saying, just put some screws and the rod and you'll be fine. You won't. But we need to measure somehow how much is enough. And in the past year, I found out that the best way of doing that is the gap score. Has been developed a few years ago, and it works. It's easy to use, and for me, it works. I mean, for many people, I'm glad to see Vinay does the same, and all the deformity surgeons, more or less, they take in consideration this score as well. So you put the parameters post-operatively. All these parameters, the relative pelvic version, the lumbar lordosis, the lordosis distribution, all these factors, and the age, and you get a score. If the score is low, is less than 2 or less, then you are safe, 100%. And I haven't had a case with a score of 1 or 2 that failed. Maybe I'm not doing a lot. But when you cross the line, again, it's different if you are in between 3 and 6. So you are moderately, the patient is moderately disproportionate. And it's different if it is above 7. As high as you go, then the fail is guaranteed. So if you manage to reach 3 with a reasonably low-risk operation, stay there and give the patient a brace post-operatively for 6 months, okay? If you are 7, then probably you won't be okay. Do something. If it is something minimum, definitely, or consider something more aggressive, to drop the gap score more. Because it's all about sagittal balance in deformity surgery, and it's not, this balance is not as forgiving as the coronal balance. So in my mind, Ibrahim will talk about this, the ladder in deformity surgery, the aggressiveness of the surgery goes up like this. You have the class 1 and 2 osteotomies, SP and chevrons. And then you do PLIFs, T-lifts, X-lifts. And if you need to be more aggressive, you go for an A-lift, which gives you a good foundation at the lumbar sacral junction. And if need be, you go for a 3-column osteotomy, which is high risk and high complication rate surgery. So I'm not gonna stay here. I'm gonna discuss a few cases with you. So this lady, she's 79. She has a T-score of -3.5. She's a smoker, heavy drinker, and she's in a lot of pain. She can't stand up. She's got this costopelvic impingement. The pain is here, the pain is in the back. No leg pain, no leg symptoms. And this is post a multiple level laminectomy at the thoracolumbar junction because of a tumor 3 years ago. What would you do? She had physiotherapy, of course. She tried the brace, she can't tolerate the brace, but even with the brace, she gets the pain. What would you do? Any idea? Would you proceed with surgery? No? Vinay won't. Anybody that would proceed with surgery?
I think osteoporosis excludes the possibility of surgery.
Okay. So you can see the parameters. They're not very good. We actually did. So we did these navigated, cemented screws. If you want to call it MIS, you can call it, but with this skin incision, it's difficult to call it MIS, but it's muscle sparing. We did just a focal open osteotomy at the apex of the curve. I think the operation took 6 hours to do. She had no blood transfusion, and she had this outcome. And I know, I thought of the same thing with you. It won't last forever. She's actually 4 years down the line now. She broke one rod. I changed the rod 2 months ago, but that's it. She's very happy, and the exchange of the rod was pretty straightforward. I mean, it was nothing. It was 40 minutes operation. Same the following day she went home. So for her it was a good deal.
The T-score, you don't treat, you just use cement augmentation rather than waiting for treating the osteoporosis, or was she not?
Oh, she had teriparatide. 3 months, sorry, I forgot to mention. 3 months preoperatively and 6 months postoperatively. Yeah. The only thing I told her, we can't operate on you until you take 3 months of teriparatide. And she actually came from the oncologist. She shorted that. So this is an example of wrong index surgery. I mean, this guy has this fusion 2 years before he came to me. For this MRI scan, I mean, I couldn't put the whole MRI scan, but there was no foraminal stenosis, no central stenosis, 3 black discs, and he had this surgery. And he came to me with a flat back, sagittal imbalance, as you can see. He couldn't cope. He's been told that he's like this because he's fat, because of his belly. And he asked me if we can do anything about that. His pain was excruciating. I mean, he's a farmer in Santorini, very, hard guy. And he was in agony. What would you do? Would you operate on this at least? Yes, or even Vinny. So everybody. Okay. So what would you do? The full Monty? Yeah? Meaning pelvis, T2 to pelvis, like the Americans. Well, what do you do, guys? Yannis? Yannis? Yes. So you need the pre-op plan. I will help you with the pre-op plan. So these are the parameters. L4S1, 16 degrees. Should be 37 plus minus 7. You miss at least 20 degrees of lumbar lordosis. Most of it should be at the, sorry, the L, that's the L4S1. Yes, 20 degrees. And the total lumbar lordosis is 2 degrees. Should be something in between 45 and 65. So you need correction of the lordosis, okay? How would you achieve this correction? Is this patient a high-risk patient? Is not. It has not comorbidities. Is the surgery high-risk surgery? It is. Because according to the planning, the pre-op planning, it requires a PSO, as you can see at L4, to get the balance, plus some cages. Okay? That was the plan. But intraoperatively, we realized after doing 2 cages that the lordosis was good. We took an X-ray and we hit the numbers. We stopped there. We didn't do the PSO. So that's why you need to change, you know, and, you know, be clever. Yeah, don't stick with a plan that is based on the information you have preoperatively. You need to get the information intraoperatively and decide and make the final decision. This is the final outcome. It's good. And it's maintained for 4 years down the line. No, 3 years down the line. This is a combination of wrong indications, wrong operations. This lady, she's 62, very active lawyer or something. Lawyer? Yeah, it's your patient. Failed operations. It started with leg pain. She was a private patient, private insured patient. She went to a hospital. Next day, she had a fusion for leg pain, hip pain. She had these 2-level fusion. If you look at the MRI, the only thing that was there was an L5S1 foraminal stenosis on the side that she had the leg pain. That you can imagine, it was the left. Because postoperatively, the pain didn't settle. So they decided it's the hip. And they gave her, day 4, a hip arthroscopy. Following the arthroscopy, the hip pain became excruciating. But they said it may come from the back. So they put these devices, the little devices here, the first time I've seen them, like a facet fusion things. It didn't work. And they decided, but they did an MRI scan of the hip. The hip was effed by the arthroscopy, and they did a total hip, which was awful. If you look at the lateral, it's awful. And eventually, she thought there is something wrong with it. She was still in the hospital. There is something wrong with the hospital. And she left, and she went to Uyugas. So what would you do with this? I mean, she is fused at L4-5. Well, she went home, actually, and she decided to deal with the situation 1 year down the line or something, 2 years down the line, because she couldn't live like that. So what would you do? Okay. The problems are what you see. Sagittal imbalance, do you see a lot? Sagittalis is regionally balanced. Coronally, there is some remaining deformity. There is a deformity which is iatrogenic, is not as bad as, is worse than it was preoperatively, believe me. And she's still left with the foraminal stenosis, which is the main symptom. And now she's got back pain as well. Plus, no, nothing. Back pain and leg pain. What would you do? Oh, she had the screw breakage, as you can see on the plane X-ray. S1 screw is broken. Would you operate? Would you deal with the foraminal stenosis only, or would you do a full correction?
No, the main problem is the leg, the pain on the leg.
Leg and back pain.
In back pain. She walks only with crutches. Okay.
What would you do? How would you deal with the foraminal stenosis? It's not mostly foraminal. It's as important as the back pain.
She's well balanced and everything. There's loads of different ways of doing each. There's lots of different ways to apply it, but I'd be attracted to taking down some of that instrumentation, doing an alien at 5-1, dealing with the foraminal stenosis at stage 1, and see what she gets, what she's like, and then reconsider the second.
Okay. We actually did everything in one go, in one setting. We did an A-lift. We took the rods out and these implants. We put screws. We flipped her over. We did the A-lift. And we flipped her back and put the rods and did the correction. And we did a cage at L3-4 because she had adjacent segment stenosis as well on the MRI scan. So that's what we did. She's dealing very good. She had a revision hip replacement for the hip. But yes, of course, there are situations that you can't do anything less than a PSO. I'm not saying that the 3-column osteotomies are out of the game. Don't worry, there is still some fun for us. Okay, and I want to thank Vasilis for all these cases because he is the second surgeon, or the first surgeon, and I'm the second. We work together on these deformities, and it's something that I highly recommend to you to do. Get a colleague that you can work together. It makes get a neurosurgeon, yeah. And Nick Gerakis used to be the neurosurgeon I worked with in the private sector in the UK.